Good evening, everyone. Welcome to the International Dermatology Education Foundation Educational Series. Spoiler alert, I am not Leon Kurtzik, though I'm filling his massive and extraordinary shoes. I'm Adam Friedman, and I'll have the pleasure of moderating tonight's session with the one and only Dr. James Del Rosso. Before I give him a proper introduction, I have a couple housekeeping items to review with everyone. So first off, I would like to thank our supporters who made this program possible to bring you a one and only novel JDR presentation. So thank you, Almirall, for that grant. Before we begin, if you're having any issues hearing the webinar, you can listen to the presentation by using your telephone. Just select the phone call-in in the audio pane, and the dial information will be displayed, and you can call in. At the end of this webinar, a survey will pop up in your browser and be emailed to you within 1 to 2 days. We would greatly appreciate if you could fill this out, as we take your feedback very seriously. If you're having any technical issues or you'd like to submit a question to our faculty, please submit your question in the questions pane on the right-hand side of your screen, and we will have time for a Q&A at the end of the presentation. And then within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. And a reminder, please submit your questions. You'll get a good sense of this from my intro, but you have a world-class master clinician before you, especially in the world of acne and rosacea, as well as in the sphere of antimicrobial resistance. So take this opportunity to pick his brain, as this certainly is an important opportunity at that. And with that, I will introduce Dr. James Q. Del Rosso, who is a fellow New Yorker and has really made a name for himself internationally as a renowned educator and speaker with countless publications, as well as is the editor of a well-known dermatology journal. I could probably spend about 20 minutes going over his accolades, but something I just want to highlight is not only does he have such incredible clinical intuition, but he's one of the best presenters I have ever seen, and really makes any topic enjoyable. Given the topic of tonight, I do want to note that he did develop and lead a scientific panel for antibiotic use in dermatology in 2005, with 3 meetings and scientific publications authored by the group under his direction to really help enable us meaningful use when it comes to the engagement and utilization of antibiotics in our practice. And so with that, I'm going to turn it over to Dr. James Del Rosso. Thank you for being here tonight.
Thanks a lot, Adam. I certainly appreciate it. I'm trying to find that master clinician you're talking about, looking for him. I don't know, where he is, but I appreciate the very kind introduction and hope that I could live up to Adam's introduction. I did found and direct the scientific panel on antibiotic use in dermatology. There were several other dermatologists and even some infectious disease specialists involved with that. And we'll be going over some of that information. We've entitled the program Targeted Oral Antibiotic Treatment in Dermatology, The Path to Optimizing Stewardship. And you can see here my affiliations. So here are my disclosures. I work with a variety of different companies that have products that some of which we're going to discuss, and do research and speaking and consult on many of those. But when we look at this overall topic, we're going to be talking about what really we need to think about in dermatology. And the scientific panel on antibiotic use in dermatology eventually fell under the auspices of the American Acne and Rosacea Society. So there's a lot of dermatologists that are involved in this area that participate in these publications. I certainly don't want it to seem like I'm the only one, because I'm clearly not the only one. But I did spearhead and write a lot of the publications. I think there are some important observations in terms of those of us in dermatology, how prescribing antibiotics relates to dermatology. And some of these numbers are a little bit older, but they really hold up today and may even be a little bit higher in some areas. Approximately 11.5 million prescriptions for oral and 6.9 million prescriptions for topical antibiotics were written looking back at 2015. We know that antibiotics, dermatologists prescribe about 8 to 9 million oral antibiotic prescriptions each year. And it's important to recognize that we prescribe antibiotics primarily for inflammatory diseases where we're not necessarily treating an infection. We're not treating an infection in these cases. The majority of cases we treat are acne and rosacea, though of course we treat infectious diseases. That's the minority. About 2/3 of oral antibiotic prescriptions written for dermatologists are for doxycycline and minocycline, and tetracycline agents account for approximately 75% of all the prescriptions that we write in dermatology. And we have to remember that we're writing these prescriptions not for 10 days or 2 weeks for an infectious disease in many cases, but we're treating acne and rosacea and sometimes some other inflammatory non-infectious conditions over more prolonged periods of time. So we have to take that into account in terms of antibiotic resistance. Now, the other thing that was very interesting was when we first developed the scientific panel on antibiotic use in dermatology around 2005, 2006, we did it because the CDC and the FDA were changing package inserts, and there were a lot of public statements that were made to the general public and to medical societies indicating that about 50% of antibiotic prescriptions were not needed. What they were talking about is they were directing it to primary care, emergency rooms, urgent cares, primary care doctors, pediatricians, and others that were seeing patients coming in in the winter, and many of them had the flu. And I put myself in their position, and I have to tell, it's probably very difficult to know sometimes whether the patient has a bacterial infection or not. So I'm not going to fault them for making that judgment. But how it turns out is that many of those cases, they didn't truly need an antibiotic because they had a viral infection. And that's where the awareness was coming in. They didn't have any idea at that time what dermatologists were doing with topical and oral antibiotics and with the number of antibiotics that they prescribed. It wasn't until later that we started to interface with them, with the scientific panel, and we brought them in to get some of their feedback. And they pointed out to us that dermatologists, if you compare dermatologists to general practitioners, internists, pediatricians, outpatient emergency care doctors, we prescribe more dermatologists per type of physician than any other group, right? And that's because of the high numbers of cases that we see of acne and rosacea. We're prescribing antibiotics, and as I mentioned, we're prescribing them for a more prolonged period of time, okay? So if we think about antibiotic exposure, that being said about antibiotics being prescribed by dermatologists and other clinicians, that's not the majority of the exposures that humans have. The majority of exposure that humans have with regard to antibiotics are from antibiotics in foods, and antibiotics gain access to water, and they're also fed to cattle and chickens and other livestock to potentiate their growth and to maximize the produce that gets out of them in terms of the meat that's sold. And that's how we get a lot of that antibiotic exposure. Now we're seeing a lot of movement to get away from farms that use antibiotics, and that's more recent, though it's still not across the board everywhere. But we have to recognize that this is a significant amount of exposure. So it's easy to think that we're just a drop in the bucket, or in the sea for that matter, and that our prescribing patterns are not making a difference. But we have definite indication that they do. And we have to think about this, especially with broad spectrum antibiotics, where we can be selecting out a lot of resistant organisms. Okay? So what is the clinical relevance of antibiotic prescribing and the emergence of antibiotic resistance in dermatology? Well, there was a study done some years back with Azithromycin 2% gel, which we don't use very much for acne, but at one time it was very, very popular, where it was applied to the face for 12 weeks. And there was an increased quantity of Azithromycin-resistant coagulase negative staph on the face and at remote sites. So it was applied to the face, but when they cultured the back or the anterior trunk or even the nares, they found resistant staphylococci, Staphylococcus epidermidis, and even Staph aureus was a resistant Staph aureus was found in the nose, and it increased from 15% to 40% in those patients that were utilizing the erythromycin only on their face. There was also an increase in P. acne strains resistant to erythromycin, and these can be on areas where the erythromycin was never designated to be applied. So you can get from touch, you get a touch of bacteria spread to other areas, or can even be spread to other individuals, and you can have resistant organisms, not only the organism you're targeting, like P. acnes, which we now call C. acnes, it's been renamed to Cutibacterium acnes, but there's exposure of any of the bacteria that are present, and we have to remember about that ecologic mischief that can occur. And this is a topical antibiotic. So we're focusing on talking about oral antibiotics, but if you use a topical antibiotic, you engender resistant organisms also. Now, what is the clinical relevance of antibiotic prescribing and the emergence of antibiotic resistance in dermatology? There was a study that was done by Levy that was published in 2003. And you have to remember, you're not going to see a lot of these studies. These are studies that are going to require private funding. They're not necessarily studies that are going to be done within the pharmaceutical industry unless they're mandated to do that for reasons by the FDA or for some reason where it's necessary for them to look at that information. A lot of this is going to be done by private funding. So this was reported in 2003, and you can see here that patients that were treated mostly with oral antibiotics, and the majority of them were getting broad spectrum tetracyclines like tetracycline, doxycycline, and minocycline. Some were getting erythromycin and clindamycin topically, sometimes in combination, but a few patients were getting just the topical antibiotics alone, but most of them were getting the oral antibiotics. And you can see here the patients that received that antibiotic therapy for at least 3 months, as compared to untreated controls that were not utilizing any antibiotic for at least 6 months, there was a substantially higher number of strep pyogenes, group A beta hemolytic streptococci, which can be a pathogen in the oropharynx. So you had selection out of that group B hemolytic strep in the oropharynx. Now, it wasn't necessarily correlated with a symptomatic strep throat in that patient, but the patient is carrying that organism, and they can certainly develop that, or they can pass it on to someone else. Also, the tetracyclines, going back to studies that were done in Europe and also some other reports, show that if you look at the geographic area and what's being prescribed in that area, you're going to see patterns of resistance of organisms related to those antibiotics that are being used. Okay. Now, can adjustments in how antibiotics are used clinically have an impact on reducing antibiotic resistance? And here we're looking specifically at changes in prescribing patterns that occur in different geographic locations. Back in the time that these studies were being done, everything that was being used was pretty much a broad spectrum antibiotic. So you can have the selection of different bacteria due to greater selection pressure. But looking at skin colonization by antibiotic resistance, Cutibacterium acnes is what we call it now at 6 centers in Europe. You can see here there was a 91% resistance in Spain to erythromycin and clindamycin, where it was widely prescribed. And in the United Kingdom, where tetracycline was widely prescribed, it was a little bit over 25%, 26.4%. Okay. If we look at the overall trends from 1978 to 1996, where we're primarily talking about erythromycin, clindamycin, tetracyclines like tetracycline, doxycycline, and minocycline, you can see a linear rise from 20% in 1978 to 62% in 1996 of antibiotic resistant what we now call Cutibacterium acnes. Back then it was called Propionibacterium acnes, same organism. okay? Clindamycin 1% gel was studied more recently for 6 weeks in patients with facial acne, and we know that there can be some resistance to clindamycin and potentially cross-resistance with erythromycin, but clindamycin does have better activity than erythromycin, and it really depends where the MIC cutoff is. So there is still some strains of Cutibacterium acnes that is sensitive to clindamycin, but we certainly don't want to use it as a monotherapy without benzoyl peroxide. And also we can get other organisms like Staphylococci, where we might be using it as a therapeutic agent for an infectious disease, we can see greater resistance to clindamycin. So we don't want to utilize it topically as a standalone agent. We don't want to do monotherapy with any antibiotic for acne. Right? So can adjustments in how antibiotics be used clinically have an impact on reducing resistance? Let's look at an interesting study in Finland where they looked at macrolide resistance. And here they were concerned about macrolides being used not only for the treatment of patients that might have acne or rosacea. So a macrolide would be something like erythromycin, and we certainly have a related azolide with azithromycin, and we have clarithromycin, which is a macrolide. They're more commonly used for infections. When there's high prescribing, you can see resistance of streptococci, right? Strep pyogenes, and also pneumococcal organisms, which can lead to respiratory infections. So they were trying to look at decreasing macrolide prescribing in the community to try to reduce those resistance patterns. And in the communities where they effectively did that, they decreased the macrolide resistant streptococcal organisms. Erythromycin resistant streptococcal organisms were looked at most specifically by over tenfold, right? By close to tenfold, 1992 to 1996, not quite tenfold, 16.5% to 8.6%. So by reducing the antibiotic prescribing and thinking about it where maybe you may not need it. If you need it, nobody's saying that you're wrong. We still use antibiotics. They're still an important part of what we do. But the point is to be thinking about how we're prescribing, and if we can reduce the overall prescribing, not only for acne and rosacea, but maybe patients that don't need it postoperatively or perioperatively, or patients that don't necessarily need it preoperatively, or for an inflamed cyst that you're doing an incision and drainage, where the vast majority of time there's never an infection or a need for an antibiotic, we can overall reduce those types of exposure. We'll talk about some of those things a little bit later. So the whole concept of trying to reduce antibiotic resistance really has to do with looking at drugs within the same chemical class and really differentiating the activities that they have. So like doxycycline and minocycline still remain very effective for Staph aureus and is still effective against Cutibacterium acnes. So, but though we've seen some climb in those resistance rates, we need to remember that those are broad spectrum antibiotics that have activity against anaerobes and also gram-negative bacteria. And so when we're utilizing them to treat Cutibacterium acnes, let's say for a patient in acne, and reduce that organism and get better prescribing patterns, we need to move back. This is jumping ahead, even though I didn't push it. We have to be thinking about that we get resistance of other organisms. Now, has all of the efforts and all of the educational noise, if you will, but important noise about antibiotic prescribing made a difference? And we're looking in 2019, a report in JAMA Dermatology by some colleagues that are very interested in antibiotic prescribing. We can see here that extended courses of prescribing of antibiotics in dermatology has gone down. The majority of that is still going to be for conditions like acne and rosacea, and is certainly appropriate in some of the patients. But if we look at the antibiotic prescribing, shorter courses, especially perioperative antibiotics, they've actually gone up. And very often for the kind of procedures that we do in outpatient dermatology, unless the patient has risk factors, we typically don't need to be giving perioperative antibiotics, and there's a lot of good data to support that. Our infection rates are extremely low. When there are certain situations to do it, such as patients have had recent cardiac surgeries where it's recommended by the guidelines, like valvular surgery, or patients have had recent knee implants or hip implants of that nature, that it might be recommended. But overall, it's not really necessary in those cases based on the literature, but I'm never going to take away that judgment from the clinician. Okay? We also have to look at, in the real world, in clinical practice, what happens to us. And I'm the first one to say that even though I think about how I prescribe topical and oral antibiotics, I'm the first one to say that if I went back and looked at what I did, I can be thought of as a quote offender, because we have patients that come in that we're treating their acne and they've been on full court press topical treatment. We put them on an oral antibiotic. They don't necessarily want to go on oral isotretinoin, or they're not necessarily candidates for a variety of reasons. They can't afford some of the devices that we might use because they would have to pay out of pocket, and they're not necessarily candidates for hormonal therapy because there are males or females that may have contraindications or not necessarily going to use those types of therapies. So we're in a situation where if a patient gets better and then their acne comes back, even though they're utilizing topical treatment, we think about re-prescribing the oral antibiotics. And maybe we do this even in patients where we might have a threshold, or they might have a threshold for oral isotretinoin. If we look at the numbers in this practice group, and they weren't necessarily seen by the same clinician each time, but they was seen within the same university structure in those clinics where they can get the records of what the patient had used. You can see here that some of these patients received antibiotics for almost 2/3 over 6 months, and over 1/3 for more than a year. So we do get into those individual discussions where we prescribe antibiotics for more prolonged periods of time because the patients need them to stay clear. But I think it's important to engender that discussion that we have to get to an exit plan, and we need to think about oral isotretinoin in some of those patients that may have been more hesitant, and now they're getting to the point that they're really frustrated with their acne. But it's easy to get on this hamster wheel, so I'm not one to criticize my colleagues, but I just want to try to encourage people to think about it. So now let's talk about some other terminology as we get into discussions of the use of antibiotics in dermatology. And these references that I'm showing you, there are 3 parts, and you can go to PubMed and you could put my name in and put in antibiotic use in dermatology, or American Acne and Rosacea Society. If you'll find these on PubMed, and you could print these out at no cost if you're interested in reading these articles. They're a little bit older, but most of the information is still relevant. Information on the new narrow spectrum tetracycline, Ceracycline, is not in this, but there are other references on that. But there's a lot of information here I think you would find valuable and help you get up to date if you've not been spending as much time reading about this, or if you're interested in it. Now, let's look at some terminology. We hear the terms microbiome, and sometimes we hear the terms microbiota. What's the difference? The microbiota is the roughly 100 trillion microbes that exist on the human body or within the human body. The vast majority of them are in the GI tract, but they are present everywhere, right? The majority of what we are is water and microbes, mostly bacteria, but there are also some other types of commensal organisms. The human microbiome refers more specifically to the collective genomes that are harbored by these organisms. So the genomes look at the DNA, the genetic pattern of those organisms, and that's one of the ways that we type those organisms. But we can get more specific by looking at the transcriptome, which is the RNA. So we hear about looking at phylotypes by looking at the 60S ribosome. We look at a typing for expression of messenger RNA, and also if there's transcription from that messenger RNA, that it's not just a bystander, it's actually active in a process. Now we talk about the proteome, where we look at proteins that are produced by these microorganisms, and then even going one step further, which has a lot to do with some of the work that Rich Gallo has been talking about, new perceptions on acne pathogenesis, looking at the metabolome, which are the sugars, the nucleotides, the amino acids, the lipids that are produced by these different organisms that may be contributing to the pathogenesis. So I think it's important to be open about this. I haven't totally wrapped my head around all the new information. There's so much, but I think it's important to be aware of it. So if we look at the potential role of the microbiome in acne, and we look specifically at where Propionibacterium are found, that includes Cutibacterium acnes, that's the sebaceous areas of the skin, and that has the lowest diversity. We see Cutibacterium organisms present, other Propionibacterium organisms present. We see Staph epidermidis, hopefully in a high enough level, because it actually counteracts. It has basically a probiotic effect against C. acnes in acne. And there are also some other organisms that might be present. And then if we look at where we have the most diverse on the volar forearm, that has a very diverse microbial community. And then there are areas that are creases that are moist, like folds, axilla, groin, even neck folds that are more moist, where you have some diversity, but you have a lot of Staphylococci and Corynebacterium. So when we're doing the studies, we have to take into account the flora that's typically there. So now let's look at what happens with Cutibacterium acnes and some other organisms in acne patients and in acne-free skin. If we look at patients with acne, you'll see in the red box, there are different phyllotypes and different ways of typing C. acnes. And certain strains of C. acnes are pro-inflammatory. They've been correlated with acne, and certain strains are not. So if an individual has a proliferation of C. acnes that is not pro-inflammatory, they're not going to see lesions of acne. It needs to be one of these types that is pro-inflammatory. And what we see is that C. acnes is the major commensal on both acne patients and acne-free skin, but it's going to be important how much proliferation there is of the pro-inflammatory types, right? Staph epidermidis is a major commensal in acne patients and also normal skin, and the concentration or the proliferation and the presence of Staph epidermidis actually combats C. acnes. So there's actually a commensal competition between these organisms, and that's a good thing because we certainly want to combat C. acnes. There are also some other organisms that can be abundant, but they tend to be in lower concentration. Malassezia organisms have been collected from young patients with acne. There are some colleagues that will sometimes see some small pustules, especially on the forehead, but occasionally on the outer portion of the cheeks. And they treat them with a topical imidazole or cyclopirox, and they do better. There may be a subset of patients that have an acneiform eruption from Malassezia, and it may be worth trying that. But that's a relatively small subset. What's interesting is the gut microbiome tends to parallel the acne-prone skin microbiome. So in patients that have acne, the gut microbiome ends up having fewer organisms like lactobacillus and bifidobacterium that tend to counteract. They tend to be probiotic type of organisms. So there is a correlation, there is a skin-gut axis that we're finding out in these patients that may have some clinical relevance. I know this could be a little dry, but I want to make sure you have some understanding before we get into the meat of the clinical part, because there's a lot of science behind this and new science emerging. Now, Rich Gallo has come up with a new concept. He looks beyond just the C. acnes, a proliferation, especially the pro-inflammatory strains, and the lipid production and the other byproducts of C. acnes that are related to acne lesion formation. He also looks at the metabolome shift and some of the other metabolites and byproducts of different organisms that are present, not only C. acnes. And this is a new area we need to be paying attention to, okay? And what we see here is from that publication that you're interested. It's very interesting because if you look on the right, when you have proliferation of the C. acnes phyllotypes, they're calling them the virulent organisms, they could stimulate acne lesion formation through a variety of different pathways that are shown on this diagram. Toll-like receptor 2, release of other types of byproducts, stimulation of the inflammasome within the cell. There are several different pathways, and also stimulating lymphocytic proliferation that we know has been associated with acne lesion formation, especially early in the process before lesions are visible. So when we give antibiotics, especially broad spectrum antibiotics, what effect are we having, forgetting necessarily about the skin and looking at, let's say, the GI tract microbiome, where we can be selecting out organisms that we're not targeting, okay? We're not necessarily wanting to target these organisms that are being selected in terms of resistance. We're treating an individual organism that may be causing an infection, or in the case of utilizing a broad spectrum antibiotic to treat acne, we're trying to selectively target the C. acnes, but the antibiotic's going other places, and it's going to have selection pressure against other organisms. So you see here studies that were done with ciprofloxacin, amoxicillin, even minocycline, looking here primarily at the GI tract microbiome. The organisms that were selected out as being resistant can persist for a prolonged period of time, even after the antibiotic is stopped. So the microbiome doesn't necessarily revert back to the wild type of organisms. You can actually have resistant organisms that can be persistent, and of course they can be shed. Okay. So let's look at a couple of other studies. I'll look at these quickly. These are some patients with acne. These patients were treated with doxycycline 100 milligrams twice a day for 6 weeks. These patients were sampled at baseline before the antibiotic and then after, and we can see the correlation with the C. acnes reduction, but we also see that there's a change in the relative numbers of other organisms that can then affect what's happening with the C. acnes, or potentially working against the C. acnes. This is another study specifically with minocycline 100 milligrams for 4 weeks. 8 adult subjects with moderate to severe facial acne. They were matched with 8 acne-free controls to look at the difference. And you can see here that I think what's important is there's a change. You're going to see the change in the C. acnes with the organism being sensitive to the minocycline, but there's an alteration in the relative distribution of organisms in the gut that are felt to be probiotic, things like lactobacillus, bifidobacterium, okay? And in the gut organisms, there's a difference in the distribution of those organisms, right? So the ecologic mischief is what we're talking about, and I think that's something you need to think about when we're prescribing the oral antibiotics for acne, especially with these broad spectrum agents. We want to think about having an exit plan and eventually getting the patient off that antibiotic and thinking about other things rather than having these patients on for months and months and months unless they absolutely need it, and we have that discussion with them. So the gut microbiome is what we think about wanting to spare when we're treating disease states like acne and rosacea. Okay, rosacea, we're not targeting a bacterium, so we want to use sub-antibiotic dosing of doxycycline or a narrow spectrum antibiotic as much as we can to reduce the effect on other parts of the body, especially the gut microbiome. So that's really where a lot of the emphasis is being placed right now. So let's move on to the concept of narrow spectrum antibiotics. And we have a newer antibiotic that came out in 2018 that was specifically developed and only studied for acne. Okay, that's Ceracycline. It was not evaluated for the treatment of infections. It was only evaluated for the treatment of acne. But we know its microbiologic profile, and I'll explain to you why we call it a narrow spectrum tetracycline. And after seeing all the information, you could decide for yourself if you feel this is clinically relevant in prescribing for your patients. But I'm going over the data for you. This is one publication where I summarized it. And it's based on several other publications that are out there that you could find. Okay? So if we look at the landscape of oral antibiotic prescribing, I already mentioned that when we're treating acne vulgaris, we want to combine it with topical therapy, and we like to have benzoyl peroxide present, right? When we give an oral antibiotic, you have to remember it's not only going to the face. So if they're utilizing benzoyl peroxide on the face, you may get suppression of resistant organisms. But what about the trunk, where there's a lot of sebaceous glands? That's where I use short contact high concentration benzoyl peroxide. 9.8% emollient foam, put on moistened chest and back, okay? Left on for 2 to 3 minutes. If you just use a wash or wash it right off, you don't get any effect on the C. acnes. That was proven even with some very popular benzoyl peroxide washes on the trunk. You have to have the contact time. And if you leave it on for 2 to 3 minutes and then wash it off, for 3 weeks, you get the same suppression that you would get of C. acnes if you left the leave-on product on for a week. So you can do that for the trunk also. You just have to specifically understand that methodology. So we try to get patients off of the oral antibiotics in 3 to 6 months if we can. Especially broad spectrum agents because of selection pressure, which I mentioned, which I covered earlier, and some of the things that are going on, and we're still learning about some of those things. We do that the best we can. The most commonly used agents have been doxycycline, available since 1967, and minocycline since 1971. Ceracycline, which is narrow spectrum, was approved for acne treatment specifically in 2018. So let's look specifically at doxycycline. Doxycycline is very widely prescribed. It's an excellent antibiotic for many different situations. It's the treatment of choice for Rocky Mountain spotted fever, regardless of the age of the patient in that situation. It's life-saving. It's used for many different types of infections, and we certainly use it in dermatology for Staphylococcus aureus, even MRSA, and we use it for the treatment of acne and even rosacea. Okay, there are some potential side effects: dose-related phototoxicity, GI intolerance like piloesophagitis. Take with a large glass of water and food in the stomach, and try to use an enteric-coated formulation if you can, right? Subantibiotic dose doxycycline, which is specifically doxycycline immediate release, 20 milligram twice a day, or the modified release 40 milligram capsule, which has a branded and a branded generic formulation, that is subantibiotic. So it's below the point of getting antibiotic selection pressure, but has the anti-inflammatory effects. That's why it's FDA approved for rosacea, and that's one of the reasons we use it for rosacea. The data does not show it to be nearly as impressive for acne. When you look at the data, if patients have the milder end of disease and they're using it for a prolonged period of time, it might be helpful for acne. Does not have FDA approval for acne, and it's not as impressive for acne, but it certainly is effective for rosacea and has been shown to be as effective as 100 milligrams daily, which does have antibiotic effects and a greater significance of GI side effects. The subantibiotic dose doxycycline is essentially devoid of almost all the vaginal candidiasis, very rare, and GI side effects are much lower. So it is advantageous for rosacea. Now, looking at minocycline, like doxycycline, is used for a variety of different types of infections. We use it for MRSA infections. It does have FDA approval in an extended release formulation for acne, not for infections, because it has a lower climb of blood levels, doesn't give you the spikes to treat an infection that you get with an immediate release. And there are a couple of different branded formulations of extended release for acne, but it's not sub-antibiotic dosing, even with the extended release. This also is broad spectrum and is used to treat a variety of gram-positive and gram-negative infections in the antibiotic doses. Occasionally, we get into some side effects which are unique to minocycline. Okay, we have acute vestibular side effects such as vertigo, because it crosses the blood-brain barrier. That's also one of the reasons why it has a higher rate of pseudotumor cerebri than other tetracyclines. Fortunately, still rare, but it does have a higher risk of causing benign intracranial hypertension. Dyschromias binds avidly to iron, and it can cause some brown or blue or slate gray pigmentation on the skin or within scars or on mucosa, like the lips, the oral mucosa, or even the conjunctiva, and even the lunula. Sometimes you'll see blue lunula. And fortunately rare, but drug hypersensitivity reactions, which typically can occur early, like DRESS, drug reactions with eosinophilia and systemic symptoms, where they get hepatotoxicity, basically similar to a phenytoin toxicity. If you recognize it, you pull the drug away. Fortunately rare, but you have to be able to recognize it. They can present like a mononucleosis, but they don't have mononucleosis. They have DRESS. Or autoimmune side effects like hepatitis and lupus-like reaction, also fortunately rare, seen more with chronic use. Now let's look specifically at Ceracycline. It's formally approved by the FDA down to the age of 9, once a day weight-based dosing for acne vulgaris, for inflammatory lesions, moderate to severe disease, can be taken with or without food. What are the relative advantages of this particular formulation? And this is based on the data. There's a lot of data to show this. Has a low risk of tetracycline associated side effects like pill esophagitis, GI upset, vaginal candidiasis, didn't have any vertigo, rare dizziness, headache. It was present but low with Ceracycline, which is good news. But I think one of the things that's important, being narrow spectrum, is it has less selection pressure against bacteria and less against the GI tract microbiome, and I'll explain why. There were structural modifications to the basic tetracycline nucleus to create Ceracycline, which change the antibiotic profile. So it's not a broad spectrum antibiotic. It has activity against gram-positive organisms. That includes Staphylococci and Streptococci, and that includes MRSA, though it's not approved for the treatment of infection. It's only approved for acne. The resistance levels, based on in vitro data, appear to be very low for spontaneous mutation. Okay. So let's look at the profiles. I mentioned it has high activity against gram-positive organisms, Staphylococcus aureus, Streptococci, Staphylococcus epidermis, including methicillin-resistant staph. The FDA allowed the company to change the package insert to specifically state that it has a low risk of antibiotic resistance with Propionibacterium acnes, which is Cutibacterium acnes, and also for the development of resistance with spontaneous mutations based on the in vitro data. That's been added to the package insert. That does not appear with any of the other tetracycline agents. They did the work to be able to show that, right? And then looking at human intestinal bacteria, I'll go over this rather quickly. If you look at gram-negative organisms like Enterococcus, E. coli, which can be very significant to our colleagues, that's considered a red flag organism for resistance in the medical community, not necessarily what we're treating, but our colleagues might be treating, and we don't want to select out resistant strains of that organism. And if we look at some of the anaerobes, as I'll show you, it doesn't have activity against many of the GI tract anaerobes and several other gram-negative organisms like Klebsiella and Proteus. Okay, so what does this mean? This basically summarizes, if you look on the right, you'll see the MIC levels for doxycycline, minocycline, and ceracycline are low, which means it's high activity. They're about the same. But if you look at against the gram-negative organisms, the ceracycline in the green is a lot higher. What that means is there's lower selection pressure against those organisms, so we would see a relative sparing of the GI tract microbiome. That's the significance. Now, what about some alternative antibiotics in acne and rosacea? Azithromycin. Sometimes we can use intermittent azithromycin in patients that did not respond to tetracyclines or could not tolerate them. I try to do this very rarely because azithromycin is commonly used by our colleagues to treat many other types of infections, especially upper respiratory tract infections, otitis media, pneumonia, bronchitis. So I don't want to select out resistant organisms. So I would do this very selectively. In older populations where we might be treating rosacea in some cases, where it also has some data in some case reports, we have to be concerned, although rare, you can get some cardiovascular changes. So I'm always cognizant of that. I may run it by their internist if they have any cardiovascular disease. Trimethoprim sulfamethoxazole, very effective for acne, but also has a low but definite risk of serious cutaneous side effects. I use it very selectively, and I warn patients, your skin gets tender, you get any sense of any type of redness or rash, or feel like you're getting any type of flu-like symptoms, you stop in and call me. I use this very, very rarely. Occasionally, you get a gram-negative folliculitis acne where you might use it. So what about outpatient manifestations of MRSA infections and other types of organisms? We reviewed this. So beyond treating acne and rosacea, okay, we'll treat folliculitis, we'll treat carbuncles. We might treat abscesses that are infected. We might incise and drain them, but we're concerned, or we culture and we get a staphylococcal infection, or we see those lesions that you do incise and drain, you get hardly anything out of it, and you know they have MRSA. Always check venereals in these patients before they're given an antibiotic, because you'll find out if there's a carrier state there that leads to recurrent infections in them or people that they're close to. If they're a healthcare provider, you have to always think about the possibility of MRSA. So oral tetracyclines are very effective. All of the agents are. As I mentioned, ceracycline has activity, but it has not been studied, but it does have activity. We know that the other agents, doxycycline and minocycline, are commonly used. Clindamycin is a plus minus. You get the culture and you do the D-test on that culture to see if clindamycin is active, but it can rapidly develop resistance. The same with quinolones and rifampin. If you're utilizing those, not as monotherapy, because there's a rapid resistance of Staphylococcus to those organisms. Rifampin has a lot of very significant drug interactions. If there are women on oral contraceptives and you give them rifampin and they're not warned to use other forms of birth control, very high rate of pregnancy, very high rate of oral contraceptive failure. There was a case in the literature of a woman that had repeated pregnancies that was on oral contraceptives and was telling the doctor, I take them every day. It was the rifampin that metabolized out the estrogen and the progesterone. It does it with many other drugs. So do not prescribe rifampin lightly without looking at drug interactions. When antibiotics may not be needed, inflamed epidermal cysts, incise and drain, extract everything from the cyst, give some intralesional triamcinolone into the wall, into the base, and they're almost always not going to need an antibiotic. I'll often culture them if there's a fair amount of pus as opposed to what looks like sebum. If there's staphylococcal infection, then I can treat them, or streptococcal infection. Perioperative wound care, most of these are clean procedures, rarely need a topical antibiotic like bacitracin or neomycin, which is going to cause allergic contact dermatitis 99% of the time. That's why you get the callback that it's red, not because it's infected. And also chronic cutaneous ulcers, unless you can culture out and you suspect the surrounding cellulitis, most of the time antibiotic therapy is not going to be helpful unless you can select out an individual organism. So I will stop at this point. I know I said a lot. Hopefully it was meaningful to you. Try to give you some of the basic science and some clinical relevance. And if I could find that guy that Adam was talking about in the beginning, I'll look for him. But if I can't find him, I'll try to answer the questions the best I can. Thank you very much for your time.
I think you're actually smarter than that guy that I mentioned before. That was a fantastic deep dive into not even just a very complex area, and it's almost like a small nook in dermatology, but it's massive. But it's evolving so rapidly thanks to so many investigators, even in dermatology. You mentioned Rich Gallo, Heidi Kong at NIH. You know, I feel like every couple of weeks there's something new, and maybe even the nomenclature will change, as you mentioned, with C. acnes. So we do actually have a couple of questions.
There are some academicians, some young academicians like John Barbieri that, you know, has perceptions that he's presenting. We have to take all of this in. We may not all agree on every different area, but other than Adam Friedman, nobody's right all the time. So, you know, we have to be open-minded, but I don't like the mindset of the feeling like, oh, you've been wrong for prescribing antibiotic. That to me, that's not the way to look at it. I think we have to be open-minded and try to get better and better.
Great, excellent point. So I actually have a couple of questions for you. Some very targeted and then some kind of more general. First question is, when using the doxycycline 20 milligrams twice a day, or 20 to create the 40, similar to the kind of branded 40 milligram controlled release, or you know, I know there are some generics of that. Would you have the patient split it up twice a day, 20 twice a day when using it for rosacea or acne, or would you have them take it all at once?
The studies were all done 20 milligrams twice a day to get the pharmacokinetic pattern that stayed below the MIC level that was felt to produce selection pressure. If you give it once a day, you may be getting more selection pressure. Probably not a lot, Adam, but we can't say that you're not getting selection pressure. So 40 milligrams of the immediate release, 2 of the 20 milligram tablets once a day, is not proven to be sub-antibiotic. The problem with the 20 milligram is if they miss that second dose, we know that 20 milligrams is not anti-inflammatory enough. And so actually, some of the early studies that were done to look at it for rosacea, the papulopustular lesion counts were half with the 20 milligram twice a day than they proved to be with the 40 milligram modified release once a day. That's because people miss that second dose. And I'll be the first one to say, when I used to take that, right, I started taking it for the gum disease when it first came out. My dentist wonders why I haven't lost my teeth. You know, it's because it has effects on collagen elsewhere, right? We use it for rosacea, but it was being developed. That's why they called it Periostat, right, for periodontitis. So we know that people miss second doses. So that's why the 40 milligram modified release once a day, if you can get it for the patient for rosacea, is optimal. If I can't get that and I had to make a choice, we have data now which will be published this month on Ceracycline for rosacea. It did very well. It's not sub-antibiotic, but it would be my choice now because of the more narrow spectrum. Some people may not feel that way. You can use doxycycline, you can use minocycline, low dose. You're going to get more selection pressure. But my next step would be Ceracycline if I couldn't get the sub-antibiotic dose doxycycline.
Yeah, I'm really glad this question was raised, because I think it's very important to note 20 plus 20 does not truly equal 40 if you're thinking about that modified release. So you do need to maintain a certain serum level. And you're right, if you miss that extra dose, which we know patients unfortunately aren't always compliant, not necessarily by choice, it does make things a little bit more difficult. But I think to the point of access, because I'm sure you and anyone else can relate, getting a branded drug can be difficult these days depending on the payer. So that's where the generic Doxy 20 twice a day can actually be very useful.
And I found sometimes they push back on that. The fact that there is a generic that is the same as the brand of the branded 40 milligram, I have a specialty pharmacy that we have better success with being able to get that for the patient. We all have these hassles. sometimes even with generic drugs, right?
Yep. Sometimes generic drugs are even more expensive than
Yeah.
the branded, which makes
Yeah.
no sense.
The topical desoxymedazone, I wrote it for my wife, right? $900, and she paid it. She said, "I thought you wanted me to have it." I said, $900, right? No going out to
That's
dinner this
interesting.
month.
No, no birthday present.
Right? No, I'm not. I'm not that way. Anyway, next.
Uh, moving on actually to another antibiotic. So it's Zithromycin. Someone asked if you need to use Azithromycin for acne. And actually, I've used Azithro 500 3 times a week for ocular rosacea. I find it actually better than Doxy for that. But for acne specifically, what dosage would you use? Would you give it twice a week or a different dosing schedule?
So what I've done, and there's a variety of different intermittent regimens. I've typically given the 500 milligrams for the 3 to 5 days, and then I cut it down to 250 milligrams 3 times a week. And that's typically the way I used it. There's no one formula, but the key is it gets such high concentrations in tissue, it doesn't get much blood level. So if you wanted to give an antibiotic for blood level, like a patient had, recent shoulder surgery implants, or I'm sorry, knees and hips, 6 months ago, you wouldn't use azithromycin because it doesn't get in the blood level, or to protect the heart for the heart valve or something like that. But you would use it where you want high levels in tissue in the skin, and that's why the intermittent dosing works, because it sustains those levels in the skin for a prolonged period of time. And that's how I've typically done it. I find it works very well in some patients. I just try to keep the use down to a minimum for
There's actually
resistance reasons.
there's some nice evidence in the cystic fibrosis literature where these patients are at higher risk for pseudomonal infections, for example, and they will prophylactically treat these patients with the 500 3 times a week dosing. And there have been a couple studies following these patients at a year or two showing no increased risk for resistance. Granted, it's only a year or two, but I think that's certainly helpful. So the point there, and I think you kind of even saw it from Dr. DeRosso's lecture, that sometimes we have to reach outside the dermatology literature to get those answers, because I found that
Well,
very helpful, made me feel more comfortable.
also there was an unbelievable study, I thought, that I learned from George Zanel, an incredible microbiologist that does a lot with dermatology from Canada. He basically works at the place that's similar to and works with the place that's like the CDC of Canada. And so he pays a lot of attention. They looked at patients that came into the emergency room and had pneumococcal pneumonia. And they looked at their patterns of antibiotics that they were on for 3 months before: azithromycin, quinolones, like levofloxacin, probably where they found that the pneumococcal organisms, the resistance rates, because of their exposure within the 3 months before, were sixfold higher, ninefold higher, significantly more because of that recent exposure. So we do select out resistant organisms, and that, getting that history, he taught his infectious disease fellows and the doctors in the emergency room, pick a different antibiotic if they've been on a different antibiotic in 3 months, because they're likely going to be resistant to that same antibiotic. I think that's very important information to glean.
Completely agree. Switching gears to topicals, and I'm also glad this was brought up, and I'm very curious to hear your opinion on this. So someone asked about your kind of go-to topical treatments. I'm going to go at the end of the question with topical treatments for maskne, and I'll add on to that question. What do you think maskne actually is?
Well, masking could be a variety of different things. People take off their mask. They may have a few acneiform papules. They tell you they haven't had acne before. I've seen perioral dermatitis type pattern. I've seen scattered acneiform lesions. In patients that have acne, sometimes it seems to be making it worse. Sometimes it looks more like rosacea, some erythema. If they have pustules and papules more consistent with rosacea, then I figure it to be a flare from that, not only from the contact, but the heat under there. It's hot under there. It's annoying during the course of the day. Uh, or sometimes it's just erythema, and you don't know if it's rosacea or contact dermatitis. Some of these disposable masks, and I've had patients that their workplace won't let them use a cloth mask that they've been using with no problem. They start to use the disposable masks like these, right? And I don't have any interest either way in the manufacturer. Some of these contain formaldehyde, right? Low levels of formaldehyde, and some people are allergic to formaldehyde and formaldehyde releasing resins. And patch testing has shown that some of these people have a true contact dermatitis. So there is some clinical decision making, and I can't say I haven't had a few that I thought were contact dermatitis. I gave them a topical steroid that probably helped their rosacea but could have made it worse. You're going to make some of those errors in judgment sometimes, but by and large, treat what you see. For the acneiform eruptions, I tend to use, I try to use a lot of azelaic acid, the 7.5%, if I can get it once a day, because it tends to be non-irritating. And I'll try to use, I use a lot of the over-the-counter 5.5% benzoyl peroxide. Even if it's just a few areas, I break the rules and I might tell them to use spot application so they don't get irritation from diffuse. Typically we're treating true acne with diffuse application, but if they're just having this in spot areas here and there, then I may tell them to spot apply. They can try it in one region. If they don't get irritated, then they can try it on the entire face.
Yeah, I'm very much in the same camp as you, and I think the term maskne is a little misleading. I think it's more in the rosacea family, and I've been actually scraping a lot of these patients and doing KOH, and I've been identifying Demodex, which is always so much fun. I take photos and send it to my residents. I'm like, happy Monday.
And the people wonder, they say Demodex is a commensal, but Demodex come out at night. They move to the Bob Seger song, Night Moves. They come out and they go from follicle to follicle looking for guess what? The same thing some guys and people go out at night for. That's what they're interested in doing. And that's when they migrate. If you could find Demodex easily from a lesion, especially during the daytime, and you're seeing a lot of them, there's Demodex proliferation. I'm using topical ivermectin. That's what I'm doing.
Same. Now you just maybe want to take an entire bath of topical ivermectin after that comment. So thank you for that visual. And I'm with you. I'm using a lot, as you mentioned, azelaic acid and topical ivermectin.
Frank Powell, who speaks at the Academy, shows actual videos of Demodex and follicles, and I'll leave it at that. It's unbelievable. Okay? Right?
This is the PG-13 webinar, so
yeah,
thank
that's
you for
okay.
that.
This is the reality of what we're dealing with, right?
Yeah, no, I'm with you. All right, and so for our final question, and then this is an off-label question, and I'm very curious to hear your thoughts. Ceracycline is a weight-based, has a weight-based dosing regimen. Do you follow that also for rosacea? Obviously, that's not what's approved for.
We did a clinical study. It's going to be published in Journal of Drugs and Dermatology in April. Leon Kursick, myself, and a couple of other colleagues. I know Zoe Dralos enrolled a lot of patients in that particular study. And the publication, you'll see it. It'll be out, where we looked at Ceracycline weight-based dosing in adults with papulopustular rosacea versus an active control. What they were given was a Centrum tablet, okay? So that they were given something. So it could be investigator blinded, obviously couldn't be patient blinded, but it didn't need to be. And the Ceracycline worked extremely well. It was about 75% lesion reduction from moderate to severe IGA, investigator global assessment with lesion counts by the end of the 12 weeks. So it worked very, very well utilizing the weight-based dosing. So that's what I follow. And like I said, I think that's an advantage being narrow spectrum as opposed to broad spectrum.
Yeah, I'm with you. I've actually been using it in my supportive oncodermatology clinic for the papulopustular eruption of EGFR inhibitors and HER2 receptor inhibitors. And it works very well. And I think knowing that, and then there was a recent label extension that you can use it for longer time periods without the risk of increasing stress on those microbial populations, gives you a little more comfort, because especially in those patients, they're going to need to be on it longer than probably 3 months, because their dosing regimens for cancer treatment is going to be longer, and it's a disabling, absolutely disabling condition.
Yeah, exactly. They're different responses, and those, and we don't even know what all those acneiform eruptions are. They're
correct.
But I think that's well taken. I don't want to give the impression that there's not going to be any resistance, but whatever we can reduce, let's try to do it. Why not? Right?
Yeah. Hashtag just do it.
Right?
I think there's something.
Hashtag,
I think something to the
hashtag
millennials in there, right?
somebody else used that line. We'll have to come up with something different.
Yeah, it's true. There is a trademark infringement there. So on that lovely note, we're going to close tonight's
Now that we're
webinar.
going to get sued. Bye.
I'm sorry, I think my wife's calling my name. All right, I hope you guys all enjoyed that as much as I did. Thank you, Dr. DeRosso, for your insight, wisdom, and your investment in our specialty. And thank you all for tuning in for this wonderful educational series. Have a great evening.
Yeah, I want to thank Roxanne and her group for supporting the program and the IT people. There's a lot that goes involved in this, and I really hope this was helpful to you. That's really what I enjoy the most is talking to the colleagues and hopefully telling them something that they didn't know. Because I know when I hear other people, that's what happens for me.
Absolutely. Have a good evening, everyone.
Thank you.